This video demonstrates phacoemulsification in a post-traumatic cataract with subluxation with corneal scar and iris defect. As usual, a temporal 2.2 incision is being made and two side ports are made. Air is being injected into the anterior chamber. Intracameral adrenaline is being injected and Zynic is being released. Anterior capsule is being stained with trypan blue dye. It is being washed off and replaced with viscoelastic substance. I prefer to use a cystitome to do an anterior capsular excess, and hence in mild case of subluxation I am continuing with the cystitome to do the anterior capsular excess. Once the capsular excess is being done, a gentle hydrodissection and delineation is being done and the nuclear movement is being ensured. After that, I am securing the anterior capsular margin where there is subluxation with iris hooks. Since the capsular hooks are not available with me, I am using an iris hooks. Make sure that you don't pull it too much while securing the anterior capsular margin. Next, we can proceed with phacoemulsification. I am doing a vertical choke. Pieces are being slowly chopped and aspirated without causing any zonular stress. Once the pieces are being removed, before taking out the phaco probe, make sure that the anterior chamber is formed with a viscoelastic substance to prevent further increase in the subluxation. So make sure whenever you come out of the anterior chamber has to be formed. Now it is clearly visible that there is a nasal 2 to 3 clock hours of subluxation. Next step is to remove the cortical matter. First, remove the cortical matter from other area and then finally in the area of subluxation. Here again, before removing the irrigation aspiration probe, inject viscoelastic into the anterior chamber and form it. Now I am removing the iris hooks. Capsule is being stabilized with an 11 to 13 mm capsular tension ring. After implanting the capsular tension ring into the capsular bag, I am implanting a monofocal acrylic hydrophobic IL in the bag. Always extend the wound a little bit so as to avoid zonular stress while injecting the IL. Now the IL is being implanted and tucked into the capsular bag. Injecting a little bit of pilocarpine to constrict the pupil. An inferior side port is being made and I am using a 9-0 proline suture to close the iris defect. Here I am using a single pass 4-through technique where using a 26 gauge needle I am hooking one margin of the iris and the proline suture from the other end. Once a loop is being formed inside the anterior chamber, it is being exteriorized and 4 nodes are being made and pulled in from both ends. Now I am cutting the sutures. Likewise I am making 2 more sutures to close the iris defect. Next, the viscoelastic substance is being removed from the anterior chamber using an coaxial irrigation aspiration probe. Air is being injected. All wounds are hydrated. That finishes the case. On post-op day 1, the patient gained an uncorrected visual acuity of 6/12. Thank you.